Good day, evening, everyone. Welcome to our webinar. My name is Heba Jabarti from the Saudi Patient Safety Center. Today you will be with us in this webinar that's presented in collaboration with the Saudi Patient Safety Center, the National Authority for Patient Safety in Saudi Arabia. The Saudi Patient Safety Center's mission is to promote a culture of safety, reduce preventable harm, and ensure a safer healthcare through education, innovation, and evidence-based policies. We will be hearing a presentation from Dr. Maher Fadel, Ms. Cara Smith, and Dr. Ali Asiri. They will be speaking to us on partners in care, empowering families for safer pediatric healthcare. Dr. Maher Fadel is the Chief Academic Officer at King Abdullah bin Abdulaziz University Hospital and a former head of the Neonatal Intensive Care Unit. He is a certified neonatologist with a fellowship in prenatal epidemiology. Dr. Faden's research interests in focus on qualitative studies, exploring families in ICU experiences. Additionally, he has led and participated in several committees related to education and wellness. Also, you will be hearing from Ms. Cara Smith, a certified child life specialist with over 20 years of experience helping children and families mitigate and the negative effects of stress and trauma related to healthcare experiences through emotional safety and trauma-informed practices. She currently serves as the Child Life Program Director for Abdurrahman's Oasis, helping to develop Child Life Program and professional in the Kingdom of Saudi Arabia. And we will conclude our presentations, actually, our webinar with Dr. Ali Asiri. He's the Director General of the Saudi Patient Safety Center and a board-certified pediatrician specializing in gastroenterology, hepatology, and nutrition. He has several leadership roles at King Fahd Medical City, including consultant, executive director of patient experience, and associate dean for clinical affairs. Dr. Asiri has contributed to national health initiatives and holds advanced degrees and leadership certifications from the University of Minnesota, Stanford, and Harvard. Now, moving along to our session, please welcome Dr. Maher Fadel. Just I want to highlight before I shift the mic to Dr. Maher that the questions will be at the end of the webinar. Dr. Maher, the floor is yours.
Okay. Thank you, Hiba, for the introduction, and welcome everybody to this webinar. And thank you for the Saudi Patient Safety Center for the invitation to present in this important day. So as Hiba say, I'm Maher Fadin, working in, I'm neonatologist and the Chief Academic Officer at King Abdullah University Hospital. So today, in the next 20 minutes, I will have the chance to talk to you with these two main objectives, is the importance of the family-centered care and how the family-centered care can decrease and prevent pediatric safety risk, and how we can engage the parent in improving the patient safety or pediatric population safety. My second objective in the presentation, how we can build the collaboration between the healthcare provider and the family to enhance and trust and safety in pediatric care. So why we are here today, as you know, the World Patient Safety Day is after today on 17th of September. And they choose this year a theme of the safe care for every newborn and every child. Why they choose this theme? So sorry, I think that. Yeah, so they chose this theme this year to share with you why they choose that safe care for every newborn and every child. As you know, the pediatric age population is a different population from the adult. So we shouldn't treat the pediatric population similar to what we are treating the adult population. Children, they have different need, different management plan, and different requirement. So every child, it has their unique requirement, unique need, and unique behavior. So we should take that in consideration when we are treating the children. They say we shouldn't treat pediatric population if we don't have the awareness and the management and rule in treating a pediatric. Also, one important thing that we have different age group in the pediatric population. So we have the newborn, the infant, the toddler, the preschool, the school, and the teenage. Each one of these categories, they have their special need physically and psychologically. So maybe Ms. Carlos will talk more about psychological need and how that we should make it as a safety for the children, but also here in the next slide, we'll talk about the physical safety for these children. So as we mentioned in the beginning, that family-centered care should be integrated in our daily care to decrease or improve the safety of the pediatric population. So first of all, let's discuss that the family is the most central and enduring influence in children's life. So by default, that family, they want to protect their children. And they want to make sure that children receive the best care and protected from any harm. So this behavior is a natural behavior for every mother and every father. Why wouldn't use this natural behavior to protect the children in collaboration with the family? So that the family-centered care, how can be integrated with the patient safety or pediatric safety. So as we mentioned that before, that children are not just a small adult. So they totally depend on the parent and the healthcare professional to provide a care for them. And also, they don't choose which medical facility or treatment methodology they want to choose. So all depend on their parent and the healthcare provider to provide for them a care. So as we say that pediatric age group, they require a special physical and psychological need that we should address in treating every child. And if you ask any child that he can express his feeling, this visit to any facility or medical facility is quite tough for them. Usually they are unprepared for any medical visit or any procedure, so that we should also take it in consideration. And as we mentioned, we have a variety of age group and age categories in the pediatric population. We should make sure that each category had been treated according to their need. So parent, as we mentioned by nature, they want to be informed, they want to be included in the care, and they want to protect their child. They want to be close with their children, and they want to be positively perceived by staff. So this concept is the main concept of the family-centered care in the pediatric population. So that how we can use the parent in protecting their child, how we can use the natural thing of the parent to protect their child. So that takes us to the main concept of the family-centered care. So it's a professional relationship between the healthcare provider and the family and the kids. So it includes involvement and participation and partnership between all these three parties. So this is the main concept of the family-centered care. So in a simple methodology that we are centering the care around the child and the family in relation with healthcare provider. So this is the main concept of the family-centered care. Then the sequence of that is what we'll talk about. So as I mentioned, this is the core principle of the family-centered care. We should provide respect and dignity to the family, so that we should respect their opinion, respect their how they will share their thought. We should respect their culture. So that one of the principle of the family-centered care it is about information sharing. So we should inform and share all the information with the family, and then we should share the information with the child according to the age group. It is about participation. So family, most of the time, they want to participate in the care. Maybe some of the chronic patients, they do some of the care, participating in feeding, participating in daily care, participating sometimes in giving medication. So they are part of the team. And the collaboration, as we mentioned, family-centered care is all about collaboration between families, patient, healthcare provider, policymaker, hospital leader. So it is all about the collaboration between all the team. So, giving that the family, they have the nature of they want to protect their child, how we can use the family to improve the pediatric patient safety and how we can enhance pediatric patient safety based on the family center care, how we can integrate both these concepts together. So first of all, that we should always engage the family in the safety discussion and decision making to ensure they understood procedure and potential risk. So, like, give an example, like we admit a patient to the ward. So, the first thing that we have to do to discuss with them about safety of the child, how we can make sure that the child is safe at the ward, and then how that we can also discuss with them how the child will be safe at home. So, it's second thing that is how we can educate the parent and caregiver about sign of complication and safe care practice at home and the hospital. So usually family, if they are like if you have a patient in the ward and we give the family all the sign and symptom about worsening of the disease and they understand the complication. So they will be the first reporter of that complication because the mother or the father who was sitting with the child so they can report all that complication. So that the third concept, how we can enhance safety, as we mentioned, communication. A family center is all about communication. How we can give the family the opportunity or the chance that can feel very comfortably to report any concern, report any errors. Like we give an example, one of the most common complication or the safety concern in the pediatric population is the medication safety. So how we can give the family the right to report when they have noticed that there is something wrong with the medication, like dosing, frequency, or whatever. So that should be encourage them to do that with the open communication. And then we say, as we said before, every child is unique. So every child, they have their unique need, unique preference, and all that should be centered around the family and the child. So we should, in the beginning, when you meet any family, and to encourage the family-centered care is how we understand the need of that child and how we can provide the care around the need of the child. So the last thing, how we can enhance pediatric patient safety is how we can build the relation and address all the concern with the family and the whole healthcare team to provide a healthy environment for the child. So then take us the main rule as we discussed here. What is the role of the parent in the pediatric patient safety? So as we say, parent is the first safeguarding of the children. They want most of the family, they want to protect their children from any harm. So we should use that in improving the pediatric patient safety. So the parent is the essential partner in the pediatric safety and any pediatric patient safety program. So we should also use the insight of the parent to provide the children need. So the family should be rich and they should be asked what is the children their child need. So how we can use that in preventing any harm to that kids. Also, let's think that how we can empower the parent to identify and prevent any safety risk. This is the most common pediatric safety risk that we can have been that kids can be exposed during the admission to the hospital or sometimes even some of it at home. So one of the most common complications in any hospital is medication error. So how we can use the family center care to decrease the medication error? As we say, like if we involve the family in the care and with the concept of family center care, like if imagine the mother, she's aware about the dose, the frequency of any medication to give into the child. So she will understand that if like a nurse, she want to deliver a medication and she deliver it before 1 hour and she by mistake, she want to deliver again the medication. If the mother understanding and we shared with her the information, so most likely she will stop that risk and that will decrease the medication error. So that's one of the common things that we can use in the family center care to decrease the medication error. Fall and injury. So we should always use the concept of that mother can protect her child from fall and injury when we educate them at time of admission, that the child should be like, according to the policy of the hospital, that shouldn't be in the side of the bed should be up and how we can prevent injury. So involving the family in that will decrease the risk of fall. Infection control. Like we saw many of the mother that if they saw a healthcare provider go to the room without doing the hand rub or washing their hands, they will stop them, because some of the mothers, they are educated that can be transmitted infection through the hand if they didn't do the hand rub. So imagine that we involve the family in infection control in the hospital, that we educate them that this is the concept of infection control. This is the basic concept of infection control. So that will decrease the risk of any hazard that deliver in the hospital-acquired infection. Infection itself, as we mentioned before, so involving the family in the family with the concept of family center care, with give them the information, the correct knowledge about the infection control policy, that will decrease our rate of infection and also will give us a lot of barrier to deliver to transfer that infection to the children. Shocking hazard. So if this is one of the major safety risks that we face in the pediatric, especially at home. So if you educate the family and the concept about the shocking hazard, how they can prevent it, how they can decrease that, that also can decrease the disease complication. So as we talked before, family-centered care, to decrease any pediatric risk with the concept of family-centered care, we should build the collaboration between the healthcare provider and the family. So effective collaboration that lead to build a trust relationship will improve the safety and enhance the health outcome. Family, we should consider the family is a vital partner in pediatric care. They will offer a lot of information, a lot of maybe improvement project if we involve them in the care. So we have to, in every pediatric population that we deal with it, we have to build a strategy to foster collaboration, trust, and safety. So we have to build the collaboration between the healthcare provider and the family and the kids. So there is some practical tip we can use it as a healthcare provider to enhance the experience of the family and use it. We use these experience to prevent any harm to the pediatric population. So we should use with the family the concept of family-centered care. We should use the language of the family-centered care. So if we introduce, especially when we have like a new admission of pediatric or any child to the world. So one of the concepts that we introduce to the family, we are providing the care not only for the child, we provide the care as a family. So you are part of our team as a parent. So we should be educated about this material, and then you should use this material to prevent any harm to the child. So we should share the safety education material. So like we should share with the family at time of the admission or during the admission how they can provide safe care to the kids, like the injury prevention, medication errors, infection control policy. So all that should be shared with them in the concept of family-centered care. Involvement parent in the care planning. I know this is one of the harsh things that we do because usually it consume a lot from our energy to involve the family in the decision making. But this is the right of the parent and the right of the child. So the parent should be one of the major part of taking the decision to treat any child. So that will decrease any complication and also will increase the awareness of the family about how their children will be treated. Document it and follow up on the safety concern. So we should use this concept to the family that we should report any concern that noticed from their side to improve the safety of the pediatric population. This is one of the cases I still remember that the concept of the family-centered care help us in preventing harm to one of the neonate. So in our unit, we use a lot of the family-centered care concept at time of admission, that we said the family, you have the privilege to attend the round, you have the 24/7 visit, you can join anytime, you can do the any care to the neonate in the NICU. So one of the families who have a chronic, like extreme preterm, one of the families that they visit their baby daily. So they are part of the team. So one of the day, the mother, she come to the team and said, I feel today my baby is not like yesterday. I visit him very frequently. I feel him less active. I'm sure there is an issue. Because he was joined with a new staff nurse, and she couldn't notice and figure that the baby have some sign of sepsis. Fortunately, because we involved the family and the mother was very well attached to the baby, and we give her the chance to be as a part of the team, we did the partial septic workup, and the baby really he had the early sign of sepsis and was treated and prevent further deterioration of the baby. So involving the family in the care can prevent a lot of harm in all the age group, even in the busy unit like the NICU. So just introducing the concept to them can prevent a harm. So in conclusion, I think family-centered care that prevent any harm to any pediatric population is all about communication, all about how we can educate the family, how they are part of the team. So we don't need like a lot of investment in building the family-centered care. Maybe we can go to the advanced care, like how we can redesign the ward or how we can change the structure of the hospital to be more family-centered care. But if we go to the basic concept about family-centered care, it's more about how we can train our healthcare provider in providing family-centered care to prevent any harm to the pediatric population. Should be that a part of the culture and safety in the hospital, and we should always including the family in the concept of safe practice for the pediatric age group. And our aim always to improve healthcare, health outcome and safer pediatric environment. So thank you. We should hope everybody is safe and we keep this population, pediatric patient in safe environment. Thank you.
Thank you so much, Dr. Maher, for this amazing talk. Now we will move on to our second speaker, Dr. Kara Smith. Ms. Kara, the floor is yours.
Thank you so much. And thank you, Dr. Maher, and thank you for everyone being here with us this evening. As Dr. Maher said as he was speaking, when we're working in pediatrics and with pediatric population, we recognize that kids are different than adults. And so therefore our care needs to be a little bit different. So today I'm going to put a little spin on how we typically talk about patient safety and focus on the whole child. So a little bit more on not just the physical safety of the pediatric patients that we're working with, but also introduce the concept of emotional safety and how when we're caring for children in the hospital environment, we're really responsible for the whole child. And so I want to start by sharing a little bit of a story. And if you've heard me speak about emotional safety before, I know there's some of you on here who I've spoken with before. I share this story quite a bit, and I think it's a really good example of how physical safety and emotional safety go hand in hand when we're caring for our children. I was working in a hospital in South Africa, and a little girl, I had just started working there. So this girl had already been admitted to the hospital when I met her, and she was admitted for meningitis, and as a result had both of her legs amputated. And I met her after the amputation had taken place. And the challenge for her came that no one told her prior to her surgery that she would be having her legs amputated. So she came into the hospital environment. She was sick with meningitis. She went to surgery. You know, and going to surgery without understanding what's going on, you can just imagine seeing these people in masks and hats and funny outfits in this room you've never been to, and everyone's just telling you to, you know, trust them, they're going to take care of you. And then she falls asleep, and then she wakes up, and when she wakes up, she has both of her legs missing. And you can imagine that that was a very traumatic experience for her. She went into a significant depression. She had severe panic attacks every time she had to go back to the operating room again, because last time she'd been there, she'd come out the other side without two of her legs. And so her recovery was very long, not just for physical recovery, but her emotional recovery was very extensive. She left our hospital before she had fully recovered and understood what was going on with her. And at the same time, and I know this probably sounds unreal, but it was real. It was like the perfect case study. We had another girl come in, which needed the same procedure to take place. But this little girl, we had the opportunity to meet with before she went in for surgery. And we explained what was going to happen. We did education around her amputation. And while that was very challenging information for her to hear, on the opposite side of her coming out, it was hard, but her recovery was much quicker. Emotionally, she was able to recover more quickly. She trusted the adults around her because she knew that they were going to tell her the truth. And when she left our facility, we left knowing that she was going to be okay. She had the resources in place. She had the family support in place, that she was going to be able to overcome the challenge of her amputation. So I share both those stories to introduce us to a concept of emotional safety. And we know that 80% of children who are entered in the hospital in a life-threatening situation and end up leaving the hospital with symptoms of post-traumatic stress disorder. 80%. So the majority of children who enter into our hospital with some sort of life-threatening illness leave with symptoms such as hypervigilance, recurring thoughts, avoidance. And so we have to recognize that in our attempt to do good for children and our attempts to help them feel physically, oftentimes we're actually doing harm and not intentionally. So when we talk about emotional safety, we're talking about the intentional interdisciplinary practice to promote resilience, healing, and trust for pediatric patients and their families during medical experiences. So in order to understand this a little bit better, I just want to step back and talk a little bit about how our brain perceives threats in the environments. And I know I'm talking to a room full of healthcare professionals, and many of you will know this information. So I'm going to explain it the way that I often explain it to parents to help them understand why their child may be responding to the hospital in the way that they are. But we know that the brain is constantly scanning the environment. Its major goal is to keep us alive and help us to survive the world that we live in. So when a threat enters, our brain will respond in a number of ways, right? So if my brain says, oh no, Kara, you're in danger, one thing it might do is try to fight back. And if you've worked in pediatrics, you've seen this. You've seen a child who's about to get an IV and they may be 4 years old, but it's taking 5 adults to hold them down because the adrenaline is pumping and they now have superhuman strength and they're fighting to get up off the table. Or you may run away, right? And you've probably also seen that in pediatrics when a child will be brought into a clinic and immediately run back out screaming that they're not going to enter, or maybe they're even running into the bathroom and shutting the door and hiding or hiding underneath their bed. And then we also will see children who just freeze, right? Just that panic response of freezing, and the brain is trying to figure out what options it has to do for survival. And the other option that we'll see happen is that kids will collapse or they'll fall asleep. And so you'll see kids who withdraw. They might keep the lights off in their room all the time and pretend like they're sleeping every time a staff member comes into the room. They might actually sleep all the time. So in the hospital, if we're seeing children with these types of responses, it's a message to us that their brain is somehow perceiving threat in the environment and is moving into survival mode. They think that they have to do whatever they can to be okay. And Lisa Dion is the creator of synergetic play therapy, and she's identified 4 threats in the environment. So 4 things that are happening in the environment that our brain perceives as threat and will therefore go into survival mode. And that first one is threat to physical safety or physical pain. So if as my brain is scanning the environment, it says, oh, this is going to hurt our body, this is going to cause me pain, then it's going to fight, it's going to fly, it's going to freeze, or it's going to fall asleep. And as you can imagine, when a child walks into the hospital environment, threat to physical safety and physical pain is at the highest, right? Kids report that one of the most painful things that they can experience in the hospital are injections. So anything involving a needle to kids is extremely scary. We also know that that's one of the first things kids say when they enter a medical facility is, I don't want a shot, I don't want a shot. So anything as simple as a shot can be perceived to kids as a life-threatening situation that their brain says, we got to do something to survive this. The second way that we might perceive threat in the environment is the unknown. So it's not so much the unknown itself, but it's what we associate with the memories of other unknown experiences, the possibility of what could occur, and that can be really scary for us. So as a child, if I walk into a surgery room and there's all these lights and equipment and machines and people that I've never seen before, my brain, in an effort to protect me, is going to say, whoa, 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 this doesn't feel safe. We got to get out of here, right? Or we got to fight our way through this. Or we just are going to freeze or fall asleep and hope that the threat goes away. So when we don't know what to expect or we don't know what's going on, our brain can perceive that as threat. And the third one, there's four, but the third one I want to talk about today is incongruence in the environment. So the brain is always looking for patterns, right? Familiar patterns, things that it can make sense of. It likes order. It likes things that are familiar. And if it can't track the pattern in the environment, then it's likely to perceive that as a threat and activate our fear response. So incongruence in the environment is oftentimes in the hospital when things aren't adding up. What I'm hearing, what I'm seeing, what I'm experiencing, I can't find the pattern. So for a child, that may be adults whispering outside of their room, their parent coming back into the room and looking distressed, but telling them that everything's okay. It might be not feeling good, but people telling them they're okay. It might be having a hunch that something is wrong, but everyone telling them that everything's okay. So that incongruence, when there's something that's not adding up, can cause us to, again, fight, flight, freeze, collapse, or fall asleep. So as we look at these perceived threats of the brain and we think about children walking into our hospital environment, we can see that threat is around every corner for children in the hospital. We can see that they are constantly on high alert, that they're typically in survival mode, which makes sense when you see the behaviors of a lot of our kids in the hospital as they try to make themselves feel safe. So what we want to promote as we're looking at the hospital, and there are things in the hospital, there are scary things in the hospital that we can't avoid. We can do a lot to help with pain, but there are things that aren't pain-free that happen in the hospital. But what we're hoping to do is to create a situation where children have a neuroception of safety. So a neuroception of safety is when our brain has scanned the environment and it's sending the message that we are safe. It's one thing for someone to tell us we're safe. It's another thing for us to actually feel safe and for our brain to say, you're safe. And when our brain says you're safe, that opens us up to be able to engage socially. It helps us to be able to foster connections with other people in the world around us. It helps us to be regulated, and it helps us to feel safe. And that's really what we're trying to do when we talk about emotional safety, is to create a neuroception of safety. And one of the ways that we can do that is by telling kids the truth about what's happening in the hospital. So if we go back and we look at our stressors, if we tell kids the truth about what's going to happen in the hospital, they have a better perception of what really is going to be physically harmful or physically painful. If we're honest about, you know what, this is going to be a little bit uncomfortable. This lidocaine injection, it feels really uncomfortable for about 10 seconds, but then it goes away. And when it goes away, it's going to make it so you don't feel the rest of this procedure as much, right? Or, you know, whatever procedure you're doing, if we can be honest with kids, then they know I'm going to tell you when something's uncomfortable. And when I tell you that something doesn't usually feel uncomfortable, you're going to be able to believe me, so they can determine from their brain whether or not this is a threat. If we tell kids the truth, it also decreases the unknown. So rather than having to walk into an environment and nothing is familiar and my brain assumes that it's the worst case scenario, I will have the information to know what is a threat and what isn't. I will have seen a picture of the operating room before I go into the operating room. So my brain is familiar, so that when I walk into that room, I can find the patterns and my brain can say, we've seen this before, we're okay. And then when I tell kids the truth, yes.
Sorry for interrupting, but our participants is a little bit confusing because you didn't move the slides. I told them you are explaining first, then you will start moving the slides. Is it that, or your slides is freezing or something? Miss Cara? Dear participants, just be patient for a few minutes. Miss Cara faced a little trouble with the connection. We will get back. Sorry for that. Dr. Ali?
Yes.
Unfortunately, our speaker, Dr. Cara, is facing a little problem with her connection. If you don't mind, we will start your part.
Sure. Let me
The
share.
participants, we will shift to Dr. Ali.
I might be back, so if it's less confusing for me to just finish, do you want me
No
to try?
worries. Yeah, sure. From my
Sorry,
side, no worries, Dr. Ali.
Yeah, sure. No problem.
Start.
Okay,
Ms. Cara, the floor is yours.
see if I can do this again. Are you seeing my slide?
Yes.
Is it showing the four perceived threats of the brain?
Yes.
Okay. Okay. So anyway, we were just saying that when we tell kids the truth about what's happening to them in the hospital environment, it can decrease these perceived threats and help children to have a neuroception of safety. All right. And as we talk about telling kids the truth about what's going on in the hospital, I just want to normalize for parents that oftentimes they don't want to tell kids what's going on in the hospital. And I don't want to create any shame or blame around that preference, because I know that, as Dr. Maher said, it comes from a place of parents wanting to protect their children. So some of the reasons that parents don't tell is for protection, right? We don't want kids to experience something negative. We want to make sure that they're safe. But oftentimes when we don't tell children, it actually creates more anxiety. I've had a number of kids who've said something to me of, I know what's going on, but I don't want to tell my parents because I don't want them to worry. So just as much as kids are trying to protect, or as parents are trying to protect their children, the children are trying to protect them. Another reason why parents might not tell is because it requires them to accept some of the hard truths. It's one thing to know that your child has leukemia. It's another thing to say those words and to say those words to the child. And then the last reason that sometimes parents don't tell is because they don't know how. They don't know what to say or what words to use in order to share that information with their children. But one of the challenges of not telling is that if we don't tell kids the truth, they're going to hear it from somewhere else. And oftentimes that may be overhearing conversations that adults are having. In today's world, a lot of kids will just get on the internet and start Googling what they think is going on and finding answers that way. Another challenge is that most often kids know what's going on. They may not know exactly what's happening, but they know something is happening. And so they may be drawing unreal conclusions about what they think is happening. And oftentimes those conclusions are worse or really incorrect. Kids between the ages of 3 to 7 have magical thinking. So they'll often come up with something far worse than what is going on, or they think that they said or did something to cause their illness. Yeah, so those are some of the things that could be going on. So it is hard to tell kids the truth about what's going on. It can be hard to find the words, but we can't protect kids from the experience. We can't protect kids from going to surgery, right? So the choice is that they're either a little anxious when they find out what's going on and they have adults around them who can support them and help them to have coping skills and give them more information, or they're anxious as they're staring down the OR room and there's nobody there to tell them what's happening. Either way, it's going to be hard. But when we talk to kids about what's going on, we build trust, and that trust is what makes them feel safe. So some of the benefits of telling the truth are that kids actually have less physiological and affective de-stress. So physically and emotionally, kids tend to do better when we tell them the truth. They tend to have better long-term adjustment. They feel safer with their hospital experience. They're more likely to seek out hospital care in the future. Telling the kids the truth about procedures such as MRI actually decreases the need for anesthesia. There's a lot of research out there that shows with preparation, and you can see in this picture some of the ways that we prepare kids for what they'll experience having an MRI. They actually can do it without anesthesia, which we know is safer for the child. It's less expensive for the hospital. Kids who know what's going to happen before it's going to happen tend to recover faster than kids who don't. And it also gives them the opportunity to develop some positive coping skills. It builds trust with the child, with the family, and with the medical team. We all become one team that are working together. When we talk about family-centered care, remembering that the child is part of that family, so therefore they're part of the team, an important member of that team. And then finally, it encourages participation and compliance. When kids know why something is happening, they're more likely to take an active part in making sure that that it goes well. So it can be a little uncomfortable to share with kids about what's going on. We may not have the words, but it can actually be quite easy. And I know I'm coming to the end of my time here, but just really quickly to demonstrate what it would look like to tell a child about a leukemia diagnosis. Oftentimes what we'll do with this little girl right here is making blood. So we talk about how the bone marrow is like a factory for blood cells. Its job is to create healthy blood cells for our body. It creates red blood cells, whose job it is to take oxygen throughout the body. It creates white blood cells, whose job it is to fight infection. And sometimes when you have something called leukemia, the bone marrow will create extra white blood cells that don't know how to do their job. And those extra white blood cells grow really fast, and they take up a lot of space in the blood so that your other blood cells can't do their healthy job. When that happens, you need a special kind of medicine called chemotherapy. Chemotherapy's job is to get rid of the leukemia cells. When it gets rid of the leukemia cells, sometimes it also gets rid of some of the healthy cells. The healthy cells will rebuild and they replenish themselves, but that might be why you feel kind of tired when you have chemotherapy. You have to be really careful that your body stays healthy when you have chemotherapy. And sometimes it'll affect the cells in your body that make hair, which is why sometimes you'll lose your hair when you have chemotherapy. But the good news is when we stop the chemotherapy, your body continues to make those healthy cells and your hair will grow back, your energy will come back, you'll be able to fight off infections eventually. So that was just a real quick example. I think sometimes when parents can hear what words we can use to explain some of these complex or scary ideas, they can see that it can actually be less scary for the child. The family then has open communication to be able to talk about what their experience is. So thank you for that. And I'm going to turn it over to Dr. Ali, who is going to talk to us a little bit about how we can educate families on patient safety and how we can do that from a systems level approach.
Thank you very much, Kara. Bismillah ar-Rahman ar-Rahim. Let me share my slides. Okay. So thank you to the organizing team for organizing this event, and it's a pleasure to be part of the panel with my colleagues, Dr. Fadel and Dr. Kara. Today we are celebrating, or these days we are celebrating the World Patient Safety Day, which will happen next Wednesday on the 17th of September. And it is just a reminder that, patient safety is something that we have to keep in mind always. Though there is World Safety Day 1 day per year, but I'm sure that it is always in our mind, and it is part of our day-to-day work for keeping patients and their families and ourselves as healthcare providers safe. Um, as you could see in the title of the presentation, two words. First, partnership and empowering. And those are very important sort of terms to be used in the, I would say, the new approach to care. Before, the care was sort of focused on the provider, on the physician, on the nurse, and the healthcare system. And parents and patients were just sort of passive participants. Their voices were not heard, and their contribution was very limited. Limited just to listening to whatever orders or information given to them from the healthcare professionals. So it was sort of one direction relationship. That proved to be not the optimal approach, and to be best helping patients, we need to do the bidirectional approach, which is the partnering with patients, engaging them in the care, empowering them to be part of the care plan. That proved by practice and by studies to be the best way that we can engage families and patients in care and get them to be active participants, which would help to improve their condition and ensure sustainability of the health outcomes. So healthcare is complex and many moving parts in the same time. Healthcare workers, machines, equipment, policies, systems. In addition to that, we are caring for the most important asset to everybody, which is health. Add to that is the acuity of care. So we don't have the luxury of making patients come when we are free to care them. We have to get them on board. We have to care for them once we receive them in the hospital. So this makes healthcare one of the most complex industries, and with that complexity comes the risk, or it is a risk-prone industry. So it comes hand in hand. The complexity is built within the system, so we will always have risk of having care not done in the best way. So mistakes may happen, failures may happen, and we have to be ready to that. We have to be aware how to handle that, how to reduce it from the first point, and if they happen, how to reduce or mitigate their impact. We know that that safety is the ultimate goal. And let me quote the saying by the Latin ancient medicine: first, do no harm. So even from thousands of years ago, it is always the first thing that patients expect is to keep them safe, not to harm them. And in our religion, Hadith Rasul salam, la darara wa la dirar. Also, the famous saying by Maya Angelou: first, or don't harm me, heal me, and be nice to me. So these three statements, first one is don't harm me. So this talks about safety, keeping patients safe. Then heal me, which is the giving or providing care to patients by effective, by best practice, by following the scientific backgrounds. Then be nice to me, which is the experience of care, the experience of handling patients and families as partners, as positive contributors to the care, and also as by doing the patient-centered care, as Dr. Maher said, and also by implementing the holistic care. So we shouldn't focus only on the physical aspect, but we have to, as Dr. Kara said, we have to focus also in the emotional part of the patients. So this all makes the experience of care. And the last point is, however, care or healthcare currently is far from being safe. As I said, it's a complex. It is a lot of issues, negative issues, and failures happen. I'll just touch on this story quickly, which will give us introduction to how failures may happen in healthcare. A patient who is known to the system, 8 years old, with cerebral palsy and constipation, and we know constipation is one of the common features of cerebral palsy. She came to emergency multiple times with pain, and she was managed as just abdominal pain with painkillers and legs as a known case. There was no focus on the new physical symptoms that the patient is having. There was no listening to the mother who was saying that my child is different from the previous, or this time is different from the previous presentations. There is something wrong, but nobody listened to that mother. So that child kept visiting emergency department multiple times. Then she collapsed at the last visit. She went to the ICU, developed sepsis, then she died. And the diagnosis was intestinal obstruction due to malrotation and volvulus. So it was not simple constipation. And if somebody listened to the mother that her child is having something different from constipation that she usually comes with, if that team implemented patient-centered care, family-centered care, listened to the family, examine the patient, look into all the possibilities, that harm wouldn't have happened. So our systems, our care still have a lot of unsafe practices, and our role as healthcare professionals is to try to reduce that risk. Quickly, I will not go into details, but as I said, our care or our healthcare systems globally still have unsafe practices leading to multiple harms and multiple deaths that could have been prevented, like 3 million deaths annually occur globally. 50% of them are preventable. So we're talking about 1.5 million that can be prevented by following the best practices, by communicating with parents, by listening to them, by putting patients first, and by putting the family-centered care as the best the approach to care. Now, focusing on pediatric and neonatal care, over about 2.3 million neonatal deaths happen annually. This is in 2023. Around 5 million under 5 years of age deaths happen annually. Now, the good news is that up to 70% of these deaths are considered avoidable. Again, we are talking about millions of lives that can be saved just by following the best practices in patient safety, engaging patients, keeping safety as one of the sort of day-to-day practice items. I will not go into details, but more about PICUs and in ICUs, infections, and other healthcare risks that happens in different areas of the healthcare and different stages of healthcare that patients go through. Now, very important, and this has been mentioned by Dr. Maher, that children are not little adults. So they have different physiology, they have different response to illness. So they are fragile and vulnerable due to immature organ systems. So this is why we need to deal with their illnesses quickly, appropriately, and effectively to prevent the long-term or lasting impact and harm that may happen. They are dependent on others. So we have to ensure that we communicate well. We have to ensure that we communicate with the right person in the right time and get the right information from the caregivers. They need care that is tailored to their age. A 1-year-old child is different from 5-year-old, different from 10 years old. In terms of system growth and development maturity, in terms of weight and based on the conditions. So this makes children different from adults. And when we approach children, we have to keep all those facts in mind. Now, Safety is a right. It's not a privilege. It's not an option that we choose to follow safety practices or not. It is a right for the patient and for the family. Previously, there was a focus on the patient's rights. So there was nothing specific about the family or children, but the World Patient Alliance and advice and recommend that if you could go to this website, World Patient Alliance website, and get more details about the specific rights for the family and also for children. So we have to focus on the specific rights for the family and also for children to ensure that we are following patient-centered care. I will not go into details, but they deserve to be read and followed. Now, having said all of that, why do we have unsafe care, and what are the factors or barriers that lead or prevent us from providing safe care? Now, limited access to care is an issue. A patient who needs the care goes to the hospital, cannot get an appointment, or does not get the care because couldn't find the care at the right time. So access is very important. Then shortage in skilled healthcare professionals is an issue. Some patients, they need specific specialties, or sometimes the shortage in nursing, for example, so the care is suboptimal, and so on. Inadequate healthcare infrastructure, either equipment or medications. Weak health information systems. Now, information availability of data and information is very important. And not only availability, but also sharing that information to the right team, as it said in the next point, which is fragmented healthcare systems. Now, when we say fragmented healthcare systems, it does not mean at the level of the organization or the system in general. You know, sometimes within the same unit, sometimes between shifts, nurses working in the shift, physicians working in emergency care, if they don't communicate with each other, if they don't share information, if they don't hand over to each other, this is fragmented care. And that will lead to missing important information in the right time that the patient needs, which may lead to harm. Cultural barriers. We need to care for the language barriers, different understanding of different terms, and so on. So that needs to be kept in mind. Then in some other parts of the world, poverty and inequality and difficulty in getting the care at the right time could also lead to patient harm and patient safety incidents. Now, so how can we do as a system? You know, we have the micro system where we talk about the patient, the healthcare provider, nurse, physician, healthcare providers in general. Then we have the meso system, which is at the level of the organization, like a medical city or a hospital. This is a system or meso system. Then we have the macro system, where the regulators work, Minister of Health, national centers. So I'll be talking about the system level or macro system level here. And, you know, addressing the previous points I mentioned will be very important. And part of it is at the system level, like improving access to care. Since you're talking about pediatrics and neonates, I think access to care for pregnant ladies, antenatal care is very important. And it is not secret to say that maternal mortality is one of the global problems in most of the countries worldwide. Although medicine has advanced in many parts, but still young ladies, they die because of poor antenatal care. And when they come to birth or delivery with lack of information, with lack of antenatal follow-up and care, they can have harm or death, even that's preventable. We need to invest in education and enhancing awareness of mothers and families at antenatal care and all during the whole journey of care, either for pregnant ladies or for children and neonates and pediatrics. Education is very important. Passing the information. How can parents be part of the healthcare team? How can a child, if he understands, can be part of the team, either in the hospital or after going home? Improve infection control practices. This is important to prevent infection, which is one of the most common harms that happens to patients. Capacity building for healthcare professionals. We need, as healthcare professionals, to be trained. We need to be aware about patient safety, not only for patients, even for us, because healthy healthcare provider, safe healthcare provider can provide safety to others. So we need to care for ourselves, for our safety, not only physical safety, but also emotional safety. We need to protect ourselves from burnout. We need to protect ourselves from workload and stress related to work. And that comes, part of it is due to capacity building and training and awareness. We need to build a culture of safety, safe reporting, learning from incidents so they will not repeat it again. We need to build non-blame culture and not to point fingers to those who does or who happens to be part of the system that has happened to be failing. So a failure of a system does not mean that the sharp end or the healthcare provider is the one to be blamed, because sometimes the factors that led to that error or to that harm are system-related issues. So this is a very important concept to be kept in mind. We need to establish national policies to ensure a regulated care that helps to ensure access, that helps to ensure adequacy for staff, and so on. And lastly, is the build national programs and care pathways that needs to be followed to ensure standardized care. For example, maternal care. And now we know that we have this OD model of care, which covers all aspects of care. One of them is safe birth. So safe birth is one of the national pathways to ensure standardized care and ensure that when neonates are born, they are born in a safe environment that can ensure safe life. This is my last slide, and just referring to some of the global organizations approaches that and advise every one of us to go and visit these organizations and others to learn from the international and global experiences. These are some of the documents and practices that have been published related to maternal, newborn, and child care. It focuses on the delivery of care and experience of care, which leads to better outcomes of care. And also, there are different standards for improving maternal and newborn care, young adolescent care, sick newborn care. There are standards, there are practices to be followed, there are statistics. So there will be a great learning opportunity for all of us. So the domains is to engage children and families and treat them as partners in care and ensure bidirectional dialogue and information sharing on both sides. Medication safety is very important because it is one of the common harms that happens to patients. Diagnostic safety, and the example that I gave, the case I gave, part of it is diagnostic error because the diagnosis was delayed or missed, and that led to death. And we observed a lot of significant number of cases of patient safety harm is due to diagnostic safety, either wrong diagnosis or delayed diagnosis. We need to prevent health-acquired or hospital-acquired infections by implementing best practices in infection control and also reducing the risk of transmitting infections between patients and healthcare organizations. Now, spawn and sick newborns, they are special category of patients. They are fragile. They need special care by specialized people. They need special equipment, and they need also importantly, more importantly, care that's patient and family centered. So we need to keep parents always aware of what's happening to their little babies. I'll stop here, and I know that probably many issues were not covered, but probably in the Q&A we'll be able to cover other aspects. I'll end by saying that safety is not just a job. It's not just a program. Safety is, I would say, a quality of care that we have to focus on to protect the lives of patients and to also protect our healthcare delivery system in general. Thank you very much.
Thank you, Dr. Ali. We have about 22 minutes left, and in that time, we'd like to invite you all into a, I'm going to share, and then I'm going to stop sharing so we can get back to invite you into a Q&A. So if you do have some questions, we'd encourage you to put that in the Q&A section of this, this format. And then we'd be happy to share in those. I'm going to start us off by asking a lot of what we shared tonight from working with families and staff working with families. It really requires trust to be built between family members and practitioners, but going both ways, right? That family can trust the staff as they bring their concerns about safety, but also that practitioners trust that when these safety concerns are identified, that it's safe to speak up as well. So the question I'm going to ask is, what's the biggest barrier to building trust between providers and families in pediatric settings, and how can we work to overcome those barriers and build that trust?
Dr. Ali, will start or ask?
It's okay. You can go with Maher.
Yeah. So I think the building the concept of the family-centered care in any hospital is starting by how we can educate the staff the importance of the concept itself. Because sometimes when we saw it in in our unit in the NICU, when we start to introduce the real family-centered care, people thought that it is more about restructure the unit, and maybe they see some of the fancy methodology about one-to-one care or whatever. So it's about how the staff receiving the family-centered care concept, how they should, we teach them how they can communicate with the families and how they involve them from the day one of the family in the ward or the ICU, the importance of the sharing and trusting between the staff and the family. So I think that if the staff, they are aware about that concept, I think that will be just cascade to the all concept. So I think that's how we build the trust. And as I say, maybe in presentation, it's all about how we communicate with the family, and we how make sure that the family understand that it is part of our practice now that we involve you in the care. So I think that one of the easiest step that we can provide to involve the family in the care. Yeah.
There's a question in the chat that Dr. Ali, I'll give this one to you. It says, many errors still occur because we fail to address the latent conditions or the failures identified during a root cause analysis. And as such, those latent failures then become the next active failure leading to error. So what are some things we can do to make sure that as those conditions are identified, we keep them from becoming failures?
Well, this is a great question, and I agree that a latent factor that's not addressed today will become an active failure in the future. So first, detecting or making sure that we are aware of those latent factors is very important. Then building strategies to reduce those factors from happening or from affecting patients. However, it's not always an individual practitioner's responsibilities. It is a system responsibility. So we need to build first or second, in addition to what I've just mentioned, we need to develop a learning system. Whatever mistake happens or an error or a harm should be a learning opportunity, and we should not allow that to happen again. And we need to develop a transparency. So if somebody identified, let's say, a nurse or a physician or healthcare practitioner in a safe environment, if that person identified the possibility of a risk and communicated with the leaders or with the seniors, that would be taken positively. But in a blame culture or non-safe culture, that would be taken against that person. So developing the culture, learning from that, the mistakes, reporting, positive reporting is very important. If you take all those and all in all, I think that would help to reduce the impact of the latent factors being active harm in the future.
Dr. Maher, how can we better educate families on their rights and responsibilities in patient safety? And the second part of this question kind of goes on with what Dr. Ali says, and how do we make sure that families know that they can report concerns without any sort of backlash on them? How do we create a culture that helps them feel safe in that?
Yeah, so I think it's all about how we can open the dialogue from the beginning with the family in the first of the admission or the first visit of the family to the healthcare facility. Because if the family feel that the staff or the healthcare provider, they are working together in providing the care for the children, and they understand their role in protecting the children, and they understand the concept that reporting any safety event have no backfire on them. Because maybe that can be background in the culture overall in Saudi Arabia, that if I report an issue, people will blame me at the end. So I think how we can explain to the family, and I think it's more about how we communicate the concept to the family at the beginning. So, and the other part is how the hospital or the facility regulate the concept of the family-centered care in their policy, and they implement it in the policy, and they do the correct action and follow-up planning for all these concerns. So I think this is how we can build the trust between the healthcare provider and the family. I think it's more about communication, and how we can perceive all the concern for the family and how we can reply to them. I think some of the unit or some of the hospitals, they assign maybe that part of the patient experience now, how they can reach the patient from the time of the admission, explain to them the hospital concept, the hospital of their participation in the care, and how sometimes they give them even some of the patients, they didn't prefer to report verbally, they give them the chance, they report through the other channel, like phone calls, or through the scanning or through the online version of like WhatsApp or any other methodology. So I think that's how we can build the trust here.
I'll give this question to both of you, but what are some of the practical first steps that our people attending here today, the hospitals that they work in, what are some things that they can start doing tomorrow to make some of the things that you've shared today become reality?
Well, this is a great question, Cara. And I think, as I mentioned, I think, and that's what I'm doing every day, is to educate myself first. How can I be a safe practitioner within my area? Because safe practice is contagious. You will be transmitting the safe practices to your colleagues. You'll be a good example. You could be a role model in that part. This is one. The other thing is to improve our communication skills. As Dr. Maher said many times in the presentation today in the Q&A, he mentioned the word communication many times. I think this is very important, and we need to know how do we communicate. And believe me, if you communicate, the benefit is not only for the patients, it's even for you. It will come back to you because you will feel the fruitful of that discussion once you have the patient or the family member happy, or at least satisfied, or at least informed, not necessarily satisfied, but informed. So this is the second point, communication. The other point, if he is a leader, he has a bigger responsibility of being the role model for others. He needs to ensure that the systems built within the unit, within his jurisdiction, if he's the director of hospital, if he's director of the unit, if he's a manager, if he's a shift in charge, to ensure that to create safe environment for those working with him or with her to report what's being observed or what could be a risk to the care. So to create a safety culture of reporting and discussing potential failures. I think these are very important points. If we start doing that, we will first improve our practice, improve our communication, improve the environment we work on, start creating a culture of safety that eventually will improve the care.
Dr. Maher,
Over
do
to you.
have
Thank you.
anything to add to that?
I think Dr. Ali mentioned all of the point. I don't think have anything to add, but maybe the one thing I think, I mean, feeling the responsibility that we had in our shoulder as a healthcare provider, that we should, as Dr. Ali said in his presentation, we should prevent any harm. Maybe if we don't do a harm, that will be better than do intervention with the harm. So I think that the concept, I will go tomorrow, make sure that there is my environment is safe. I'm sure that also my staff is there aware to prevent harm, and also building a culture of no harm and reporting any safety event, because we know that a lot of the staff, we have still the fear of reporting the safety concern. So I think building the culture and the communication that Dr. Ali is the main hierarchy in that concept of what we'll do tomorrow. Yeah.
If I may add something, Kara, patient safety has been traditionally sort of reactive practice. Something would happen, harm or failure, then we'll start why it has happened, how to prevent it in future, which is good. But now we need to move to a sort of a better level of that, which is safety too, or to be preventive. How can you prevent it from the first point of not happening? And that's very important. As we said, if you develop a learning culture. So this is important. And the other thing, it is taking the safety as not just as a burden on us, or because of the policy says you have to do that, or because the regulation is mandating us to do that. It is to protect the lives of patients. It is to protect ourselves as healthcare providers. So if we look into safety as something that we have to do it because it is a value, it's not because it is a task that we are asked to do, not because the policy says that you have to do double check of the medication. It's not because the policy says that you have to communicate. I'm doing it because it is a value. And if I could share with my colleagues quickly in 1 minute a sad story that has happened, just to tell how what we are talking about is a reality. It's not just written in books. In the last couple of months, few months ago, in one of the hospitals, 2 patients died in the same unit with just 1 hour difference because of giving the wrong medication, KCL, to the patient instead of water for injection. They just collapsed and died a few months ago. So what we are saying now, what we're trying to draw the attention to is real. People may lose their lives. People might be harmed. Every day, globally, a patient gets wrong side surgery. A patient got infection. a patient got fall. I remember an old, about 70 to 75 years old man, but otherwise he's okay. He's dependent on himself. He goes to the mosque alone. He enjoys his life. He walks from time to time. Came to the hospital with pneumonia, and the plan was to treat him for a week and send him home because of load of the nurse on the nurse. She cannot take care because she has a lot of patients, busy unit. That patient fell from the bed, had hip fracture, stayed in the hospital for 2 months, then discharged on a wheelchair. So his life has been damaged. He's not dependent on others. He cannot move outside of his room without the help of others. So he became now dependent on others, and his social life has changed. His emotional life has been damaged. So what we are talking about is in a real life that we are responsible as a team, as a system, to reduce those harms and deaths.
Thank you. There's a comment in the chat that go ahead. Did you have something to say, Dr. Maher?
I think, as you try to say, I think we should be very aware that we are part of, I mean, we can build any program, we can build anything, but we should build in the staff that they are the first barrier of any harm. I remember a different story. I mean, one of the staff he was walking in the garden in our hospital, and that day was windy. So one of the tree was moving like abnormally, like it was almost to fall down. So he went to and reported immediately to the security. And fortunately, alhamdulillah, he prevented the harm that tree could fall in any patient or any staff to have so they cut the tree and they prevent the harm. So he have the sense and the awareness that he is a part of the team. He needs to prevent any harm. So I think, as Victor say, it's more about how we are aware. For sure, the policy and procedure is the first line, but I think we are the first line to prevent the harm. We should be proactive. We should be involved in preventing the harm. So I think that we can prevent many harm if we have the concept that we are the major barrier of and preventing the harm to deliver to the patient here.
Thank you. I'm seeing there's other questions in an area that I wasn't looking at. So I'm gonna I wanted to share something that was more of a comment, and if you have a comment on it, you can share that. But they were just talking about the importance of teaching patient safety at the undergraduate level and how that will impact in the future. So I guess that question may stem from what different levels are we teaching this information at, and how is it maybe being received? I don't know if you have a comment on that.
Yeah, I can comment on that, Cara. And the patients, Saudi Patient Safety Center is a national regulator for patient safety. So about a year ago, we got from the royal decree or from the royal cabinet sort of a direction that we have to engage patient safety education in universities. So we are working we are leading a national initiative to embed patient safety education in all healthcare related colleges in the country. We are working with the Council of Universities, and there is a progress in that regard. And hopefully, that work is being done jointly with the Saudi Commission for Health Specialties. So we are working on that. To keep my answer short, yes, we are focusing because we believe that investing in the new generation would make it easier to have that concept of patient safety in the future.
Great. There's a couple questions on here that came from me, so I'm going to answer those real quickly, and then I have one more question for you to wrap us all up. One question was about how we can help children accept limitations due to genetics, whether that be short or developmental or growth limitations. And so just really quickly, the best way that we've found here in Saudi Arabia has been through storytelling. So through books, whether we write the book about that child or find books that help kids embrace who they are, that's been the #1 way we found. And then someone asked for educational materials for pediatric patients that are age appropriate in hospitals. So I'm going to direct you to Abdul Rahman's Oasis, which is the organization I work with. We're currently translating a lot of our materials into Arabic, so hopefully those will be more readily available. And then I'm just going to put in the chat a name of an app which again is in English, and hopefully it'll be translated to Arabic soon. But it's called Simply Sayin, and you can just find it in the App Store. But it is it's made by Phoenix Children's Hospital in the United States, and it basically has every procedure that a child might face. You can just click on the name of it. It'll show you a very simple prep for that procedure. You can push a button and hear all the MRI sounds before a child does MRI. So that's a good, very simple app for people to check out. And so then the last question I have to kind of end us on a positive note is, where have you seen success in patient safety, success in partnering with families? If you have a story or a time that you've seen how patient safety has worked, training our staffs or educating our families, maybe a success story of some of the things we've shared tonight.
Yeah, if I may, I like what you said, Carla, that we need to end with a positive note. So what we have been saying, deaths and harms, and this is the negative side, but there are a lot of positive practices that we have to keep in mind. And I'd like to thank everybody who is really sharing a positive or being a positive contributor to the care of patients. We have a lot of positive stories, but or practice that we could do. One of them is, since you're talking about engaging patients, is patient and family advisory councils. And before, like 10 years ago or more, you will hardly find a hospital here that's engaging patients on that level with a structured process. However, now I remember when we started that, like in 2014 or 15 in King Fahd Medical City. Now I think I see it in many hospitals. So this is one of the good practices that we could patient family advisory council, where patients they sit with the hospital leaders and they give their comments, and through a structured way, then those comments will be taken as an improvement, sort of to guide improvement in the hospital, and so on. So this is just one of the, and I've seen that in Cleveland Clinic, I've seen that in North Carolina hospitals, but now it's sort of one of the standards in many hospitals in Saudi Arabia.
Excellent. Dr. Maher, do you have anything?
I mean, maybe in a smaller level, because I mean, in the NICU, I think the family centered care is you see the impact immediately, and you see the impact after years. So I think one of the great story, I think, when we start to really introduce the family centered care to the unit, I remember one of the extreme preterm. I think the father came after 4 years from discharge, because we follow them in the follow-up clinic. And he said, like, I still feel this is my home, because you had been, I feel like home, like the staff was, I feel them like perceive me, they know my need, they know how my emotion can change. So I think this is how we can feel the impact of our involving the family in the family center, in the concept of family center care, because that could impact the family now and in the future, especially in the area with very stressful area like the ICUs, and we know the impact like on the mother when they admit their baby to the NICU, that could have long impact. So we can decrease that impact emotionally on them by creating these family centered care concept to prevent harm to the child and to the family.
Excellent. Well, thank you, Dr. Maher. Thank you, Dr. Ali, and thank you for everyone who's attended tonight. I think the overall message that we found out is that to ensure patient safety, whether it's physically or emotionally, that it takes the providers, the families, and the whole system working together to make sure that everyone is safe. So I appreciate everyone here who's working to do that. I appreciate our panelists who are sharing their expertise in that area, and happy World Patient Safety Day on September 17th to everyone. Thank you for being here.
Thank you,
So
everyone.
it's a pleasure being with you tonight. Thank you very much. Have a good night.
Thank you, everybody.
Good night.
شكرا مع السلامة.
يعطيك العافية دكتور علي. Thank you, Carl. Bye.
Thanks, Carl.